Hey you guys, welcome back. Today we'll be going through the nitty-gritty of the cardiac cycle. So let's start with the electrical events. Of course, there is depolarization and repolarization. That is how everything really works. Let's start from here. This is going to be your SA node. And of course, remember from the last lecture, P wave is going to show the SA node depolarizing. Goes through, remember, to the other atria and through the Bachmann bundle, and the atria contract, finishing off the P wave. And then there's the PQ segment as it continues to depolarize, and that's the atria contraction. And then the Q wave occurs when the AV node, after that pause, it's going to depolarize down the right and the left bundle branches, making the Q wave. And then the R wave is going to occur as it travels down and through the Purkinje fibers. S wave, there's more propagation. And then during the plateau, the ST segment, the ventricles will contract. And then there's going to be repolarization causing the T wave. And then once the finish of the repolarization, the heart is primed, and then the atria will depolarize again. And remember that the QRS segment is so massive it hides the repolarization of the atria. So the point of depolarization is to release calcium, and that will of course lead to the cardiac muscle to contract because the calcium is now available. And then there's going to be all these pressure changes, volume changes, and valve closure during the entire cycle. And the right atria is where the pressure is the lowest, of course, because here's the start. The blood has to fall in from both the superior and the inferior vena cava, and it only falls into the atria if the atrial pressure is low, like a vacuum. It will suck the blood in. And then in the aorta, it's going to have the highest pressure because you have to push the blood out into the aorta, and that's going to have to be strong enough to perfuse the entire body. The lungs have the lowest pressure in the body because, of course, this is going to be where the blood and oxygen exchange occur, and the oxygen has to be, once again, like sucked into the blood, and the carbon dioxide has to be released, and that occurs because of the negative intrathoracic pressure. Okay, so this is a lot of details, but the more important thing to know is that the ventricular filling is going to be, there's going to be two types, rapid and reduced. Rapid, of course, is the quickest, and then reduced is going to be like a little bit later after the initial rapid filling, and it kind of like fills the very last bits of the blood from the atrial systole. And ejection is also rapid and reduced. So first there's like the initial just release of the blood, and then like the final squeeze, that's going to be like the reduced. Atrial diastole is going to be the very slowest of the process, or of the process of the cardiac cycle, because it has to wait for the entire blood to circulate through the body and into the inferior and superior vena cava and then fall in. So it's going to be the slowest just because it has to wait the longest. So let's look at this chart. So systole is pretty fast, squeeze into the ventricles. It's about 100 milliseconds. And then the ventricular systole is a little bit longer, about 370 milliseconds. And then the diastole is also pretty slow. It's from 370 milliseconds to 800 milliseconds, and then it goes and starts all over again. Not too important to know about like the numbers, the actual time. You just need to know that And the longest time is going to be atrial diastole. The second longest is going to be ventricular diastole. And know that ventricular systole and diastole is going to have the rapid and the reduced phases. So, what is isovolumetric ventricular contraction? That's when the ventricles are filled with the end diastolic volume from the atria. So, all the blood in the atria goes into the ventricles. And then the preload is going to be your end diastolic volume, and that's just related to the right atrial pressure. This is what we measure to determine whether a person has heart failure or not. And it's just like preload is just related to the right atrial pressure. That's important to know. Preload increases when venous return increases, of course, because more blood goes into the right it goes into the right atrium and it stretches the atrium more, thus pressure increases and preload increases. The ventricles will fill and the pressure increases, and then the valves close. So you can see here, so the valve close, and then the pressure remains at the end diastolic pressure, and then it squeezes. So with the isovolumetric ventricular contraction, the ventricles will squeeze, the valves will be closed. So no blood is going in and out of that ventricle, and then the pressure reaches a certain amount, then the aortic valve will open, and then there's going to be ejection, the relaxation, rapid inflow. The aortic valve will close, and then it's going to once again open down here, and then the cycle starts all over again. Open so it can fill. This is going to be the atrioventricular valve, not the aortic valve. So this closes, this opens, filling. This is going to be the isovolumetric relaxation, and this is going to be your best friend, this chart. So I rarely recommend studying this chart and being able to read it quickly. So this is going to relate to the volume, so it makes sense. Like, look, so AV valve close, and then when the aortic valve opens, there's going to be all that ejection, so of course the volume goes down, and then when it closes, it starts rising. When the atrioventricular valves open, it rises some more, so more volume goes into the ventricles, and then same thing. This is going to be like the heart sounds, systole. Of course, this is going to be your lub. So the AV valve closed, the blood will hit the walls and makes the lub. And then when the aortic valve closes, it's going to make the dub, or the aortic and the pulmonic valve. It's because those two close at the same time. Okay, so the ventricles will squeeze. It's like squeezing a balloon, right? So it will squeeze until the pressure in the ventricle exceeds the pressure in the vessels, and then the valves are popped open and the blood goes out. So here you go, AV valve close, and then aortic pressure is about here, right? So we go past it, bam, they're open, ejection, and then the pressure also increases in the great vessels, because there's more blood now. And then when they close, there's going to be the relaxation, and the reduced ventricular ejection doesn't really show here, but like here's, let's say this is the rapid ejection, and then like maybe here there's going to be the reduced. So the pressure reduces, and the ventricles have to squeeze a little bit harder to get the tiny bit out. So like when you're squeezing toothpaste, first when you squeeze like a full tube of toothpaste, it comes out really easily, right? Until you're at the very last like fourth of the toothpaste, and then all of a sudden you have to squeeze a lot harder. So the end systolic volume will always remain the same. Ventricular relaxation is when the pressure in the ventricles relax, and then blood kind of comes in. It's also known as diastole. So you should know these terms. I will use them interchangeably. But anyway, there's going to be the rapid ventricular filling when there is this is going to be the max filling, and it makes sense, okay? So when the pressure it has decreases to a certain amount, the AV valves will open, and then blood will just fall in, right? But once the pressure rises, and the blood doesn't flow in as quickly, and it makes, it slows down because of the high pressure gradient. And in some cases, it can make an S3 sound. So S1 is lub, S2 is dub, S3 is going to be like a sploosh. And interestingly enough, this can be a good and a bad thing. It's bad in the elderly because that means that there's going to be some kind of like stiffening of the heart. There's going to be some stenosis of the vessels, or reduced elasticity of the atria. But in a healthy young athlete, let's go back to Michael Phelps. His heart is very healthy, and he is much larger than I am. But more importantly, his heart is going to be incredibly effective in contractility. So since it contracts so well, it would also relax more than my heart, let's say, would, because of the elasticity and contractility and the tone of his muscle fibers. So the heart will be able to stretch a little bit more, and the blood will fall in, and there's so much blood that can come in, it makes a sploosh sound. So atrial systole is going to be the contraction of the atria. It ends at ventricular diastole, so it's already starting to contract before the filling of the ventricles actually end. So a small amount of the blood will fill the ventricles, and that can make an S4 sound. And an S4 is always bad because that indicates some kind of heart failure. There's going to be a stiffening of the ventricles. And then the ventricular volume will reach something called the end diastolic volume. Makes sense. It's the end of diastole. The ventricles have reached its max volume, and it's going to be the ventricular volume. That makes the ventricles ready for the next systolic phase. Let's go through it again. SA, AV, technically to the Bachman bundles. Never forget the Bachman bundles. NBME, board exams, STEP. Always love to test you on why the atria contract together, this, that, and the other. So let's go again. P wave, this contraction, P, and then this is going to be the PQRS. Sorry, PR segment. This is going to be the contraction, it continues. So here's going to be depolarization. Here's the atrial contraction. Remember, the AV node will delay the impulse, and then there's going to be the sending it down the bundle branches, sending it down to the Purkinje branches, perfusing through the rest of the heart, through the ventricle. Contraction is going to be the QT segment, and then it's going to repolarize. Well, the ventricles are going to repolarize in this area, or in the T wave, I should say. So the arterial pulse is going to be the blood filling of the peripheral vessels, and it's important to know because it shows the health of the vessel and the strength of the heart contraction. Alrighty, so we look at the radial pulse in the arm, the external carotid in the neck, the dorsalis pedis in the legs, and the femoral in the inguinal, or the groin region. So the percussion, or the tidal wave, is due to the ejection of the blood during ventricular systole, so it's going to be the upstroke. And then the dicrotic wave is going to be the rebound of the blood against the closed aortic valve during diastole, aortic or pulmonic. The arch is going to be the closure of the valves, and it's going to also coordinate with the lub dub sounds. So this is going to be dub. And so how does this show the health of the vessels and the strength of the heart contraction, right? So it can show that the vessels are either occluded, you won't feel a very strong pulse, or like you can feel like irregular beats from the heart, or if the patient suffers from hypertension, you're going to feel something called a bounding pulse, and that's when the pulse feels like it's jumping out of the skin against your fingers. In some truly terrible cases, you can actually see the pulse like just usually we see it at the neck. We can see the pulse just like go wild, even at rest. Okay, so we'll get through that in a little bit. The jugular venous pulse is going to be the pressure in the right atrium. So this is what it measures. And this is important because the IVJ has no valves. So it will transmit the pulse like perfectly. There's no valves to interrupt. The normal value is going to be 6 to 8 centimeter of like water pressure. And there's going to be a couple ways to know. The A wave, this is going to be the right atrial systole. The C wave is going to be the closed tricuspid or the ventricular contraction. And then, this is going to be the X descent. C wave, sorry, systole. The X wave is going to be the closed contraction. And the V wave is going to be arterial or venous filling. And then the venous pressure will increase because the tricuspid is closed. And then Y is going to be the passive emptying into the ventricle. So I guess this is a pretty nice graph about this. So A, S, K, M, E, contraction, systole with the C, X with the K, M for the V wave, and then E. So A, S, K, M, E. Sounds like a test, isn't it? Okay, here. This is what I'm talking about, the bounding pulses. So this is known as JVD, so jugular venous distension, and it's caused by something like constrictive pericarditis. So the heart is inflamed and it's constricted by the pericardium, so it can't like actually pulse correctly, it can't contract correctly. And it's also caused by tricuspid valve stenosis, which leads to right-sided heart failure. You guys remember tricuspid is on the right side, and that also leads to pulmonary hypertension. And from there, it increases the central venous pressure, of course, because remember, pulmonary should have the lowest amount of pressure. This should have the least amount of pressure in the body, and with the increased pressure, there's going to be less oxygenated blood going back into the heart, and then the heart's going to have to beat faster to perfuse the body better because there's no oxygen. And then that's going to increase the central venous pressure because the heart is working faster. Heart works a little bit too fast, too hard for too long. So this is like not acute kind of disease. It's like chronic. There's years and years and years of this. Eventually, there's going to be the tricuspid valve stenosis, which makes the heart beat even faster and harder because, the body needs blood, and eventually leads to right-sided heart failure. So this will also show how well the heart is flowing, the blood is flowing back to the heart, and how well the heart contracts. And you identify this by getting the patient in a semi-recumbent position, and recline them at like 45 degrees, let them relax, and you take a peek at their neck, and then this is going to be a big old vein popping out, and it's very obvious. And in bad cases, you can actually see the pulse just like go like through the vein. Okay, so let's go through the pressure volume loop. In phase 1, there's going to be mitral valve closing, isovolumetric contraction up into phase 2. Phase 1 has the highest oxygen consumption because that's where the deoxygenated blood is coming. It's going to be coming into the either the right atrium, or the oxygenated blood is going to go out. But since it also is like the longest period where the filling, it's going to have the heart like work a little bit more. So in the second phase, the aortic valve will open, and then this is going to be systolic ejection. Phase 3 is going to be the isovolumetric relaxation once the aortic valve closes, and then there's going to be the relaxation diastole phase, the mitral valve will open, and then the atrial will fill. Remember, there's going to be the rapid filling and reduced filling phase, and then there is going to be, this is the other loop. That's really important to know. So for some strange reason, it goes like, counterclockwise. So here is the mitral valve closing, opening, the contraction, aortic valve closing, relaxation. So the vertical lines show the isovolumetric contraction or relaxation. The distance between the two lines is going to be stroke volume. Okay, what is it? Stroke volume normally is about 120 to 150 milliliters, and remember the rapid filling and the reduced filling. There's going to be the isovolumetric contraction, and that is when all of the heart valves are closed. So it's not going to be, it's like that very one tiny bit of time where all of the heart valves are closed. Like, you remember they do open like one at a time, but for a couple like milliseconds they all do close, and that's the isovolumetric contraction and relaxation. So the afterload for the left ventricle is going to be the aortic pressure. Of course, this is the left ventricle has to overcome in order to pop those valves open. And for the right ventricle is going to be the pulmonary artery. So preload is going to be the end diastolic volume. It's how much the ventricle or atria is stretched at the end of diastole. So if you increase the preload, stroke volume will increase. Why? Because there's now more blood to squeeze out. There is the curve, the EDPVR, and that depends on the relaxation of the ventricles, and it shifts to the left if there's higher pressure due to the decreased relaxation and recoil, while the ESPVR is going to be the inherent contractile state of the ventricle. So this is going to really show if there's any stiffening of the ventricle or not. So it shifts to the left if the contractility is increased. And all of this is related to the positive ionotropic effect. So ionotropic effect is how well the heart contracts, and is ionic because it depends on like calcium along with like sodium and potassium exchangers. So here's the EDPVR I was mentioning before, and the ESPVR. So preload, contractility. So let's go through the phases again. So 1 to 2, contraction. There's going to be opening of the semilunar valve. 2 to 3 is going to be ejection. 3 to 4 is going to be the isovolumetric relaxation. 4 is going to be the opening of the AV valve, and then there's going to be filling from 4 to 1. And then go back to like 1, and that's the end of the diastolic state. Close the atrioventricular valve. So the isovolumetric side, this is going to be the potential mechanical work stored in the left ventricle wall. So this is kind of similar to the right ventricles. This would be a little bit smaller since the right ventricle is a little bit smaller, but essentially the pressure volume loop is going to be the same. And it's important to know this chart like the back of your hand. Sorry if it sounds really repetitive, but that's just the way it is. Okay, so thank you for your attention and good luck studying. Just helpful hints, go through some clinical scenarios like what if the loop is like taller, shorter, wider, narrower, whatever. This will be really handy when you study for your boards and for your shelf exams and for your STEP exams, so good luck.